Well, this is the topic I want to share my experience today. Part of my brief CV, part of my conflict of interest, but I don't have any conflict for this lecture. First facts, there isn't biological inner filler material. If the immune system is competent, it must be able to recognize and react to this foreign element. And the third one, this reaction can be early or late, and the magnitude of the reaction is specific to each individual. These all are words from a friend of mine, the pathologist Paulo de Sanson. I really believe on these three phrases. Looking for more info, I recommend you to read this lecture for this paper from Luis Requena and collaborators, the adverse reaction to injectable soft tissue fillers. And here is the free download if you want to read it. And he explained that all cosmetic filler may induce other reaction, complications secondary to biodegradable or ultraviolet filler will disappear spontaneously or in a few months, but no resolvable filler may give rise to several permanent reactions. All these particles of each filler have a specific microscopic characteristics and allow to identify the responsible filler. That means we can obtain a complete info of the filler by biopsy or even with the ultrasound diagnosis. But as you know, even hyaluronic acid, as my colleague told you a few minutes ago, can cause granulomatosis reaction, and even hyaluronic acid may cause ASIA syndrome. That's why it isn't any kind of completely safe soft tissue filler. These are the complete list of any kind of filler that was performed on the face in the past, nowadays, and in the future. And this is a friend of mine. I recommend you to read these papers. This about Jimena Wurzman, sorry. He's from Chile, and he proved the different kind of image we can obtain with the sonograph when I try to find the origin of the filler. I started mentioning that in my country, Argentina, until 2019, these two kind of permanent filler was allowed, PMMA and polyacrylamide. I never used PMMA, but in the past I used polyacrylamide. Well, in which way we need to act when we have this problem with synthetic facial filler? Where first identify the type of synthetic filler, as I mentioned, with diagnosis with a sonograph or with a biopsy. And as a plastic surgeon, I always say that to my colleague, there is always time to cut. If you can minimize access, try to do it, try to minimize, and after that, you can cut it. Technology are not the solution and can be a problem. You can be the responsible to the migration of any kind of permanent filler, and be careful when you aspirate any kind of permanent filler, because you can spread the filler and at the same time you can spread healthy tissue as fat cells. Case and results, I start with silicone oil, usually cause migration and extrusion, and the granulomatosis reaction is less than the solid silicone. You never can find here capsular contraction. But usually you have that when this silicone oil migrate, always go to the mucosa of the inner part of the upper lips. And here is the proof in a close view. The patient disagree when she's give a big smile. And this is the way I can solve it, cutting the mucosa. And here is before and after. Here is the silicone oil, and here is the silicone disappear by a cut, by the surgery. And this is the way our pathologists and our sonographers identify the silicone oil as diffuse inflammatory infiltrate involving the reticular dermis, cystic space backwall of different size and surrounded by multinucleated giant cells, and is hyperechoic deposit with posterior reverberations. You usually use the phrase of a snowstorm. When you talk about polyacrylamide, it causes granulomatous reaction and migration. But in the first 6 months, if you have the problem as infection, I show you and improve the way I can punch it and squeeze it. Of course, it's impossible to remove all the filler, but majority of it. And by this, we can we add antibiotics, of course, but we can solve the problem. And with this other patient that disagree with my result, in this case, I put this gel in the tip of the nose, and he looked for a permanent solution. He looked for a rhinoplasty. That's why, first of all, I squeeze again the filler. Here is the way I squeeze it. This is the way I have a droppy nose again, because I take out majority of the filler. And after the rhinoplasty, the patient are completely agree with the result. And this is the way, again, our pathologist and sonographer identify the polyacrylamide hydrogel. Is granulomas at different levels of the dermis, macrophages, and foreign body giant cells, one the basophilic multivacoated material, and finally hypoechoic pseudocystic with echos inside and with greater hyperechogeneity in the peripheria. This is the typical image in the sonograph. And the last one, PMA, can cause nodular or diffuse granulomatous foreign body reaction at deposition of fluid tissues, but never migrate. It's always inside, always in the area where we put it, is when they cause all this alteration, but never migrate. And this is the patient asked for a solution. Here it is. You can see a complete asymmetry made by this excessive PMA in the left part of the cheek. And this is the proof that she used this kind of PMA on him. And this is another proof with the CAT. You can see here the way an increase on the layer of the skin by this. I measure the size, 31 by 70 by 40, and I perform the procedure with ultrasound guide, trying to take out majority of this filler. If you pass the cannula inside of it, it's like you pass over a wood, but you can take part of it. As you can see here, the way I take a part of it. And here again, before and after, before and after, you can measure the way I can reduce this huge granulomatous reaction to only these few little that the patient are really happy with my aesthetic result and the symptoms result too. And here with a big smile, he recovered again the normal nasal labial sulcus or row. And this is the way our pathologists and sonographers say that it's PMMA, because have nodular or diffuse granulomatosis infiltrated, surrounded with vacuola, similar shape and size, and hyperechoic spot with mini comet tail artifact. When we measure complication adverse effects of the hyaluronic acid, there's this great huge list, but I only put focus over amaurosis. As you know, I've read of papers, a lot of published talking about that. And of course, amaurosis is similar or equal to, say, hyaluronic acid over the retina artery occlusion. I have the opportunity to be the moderator of this guy, Claudio De Lorenzi from Canada. And when you ask him about how avoid to minimize the risk of filler inadvertent vascular injection, he gave me this four advice: slow and sparse movement, inject slowly, low volume, and large caliber cannula. Because I always prefer skin necrosis when you compare to amaurosis, brain damage, or death. That means that if we do it exactly opposite of this advice, you use fast and localized movement, inject quickly, large volume, and small caliber cannula, you can overcome the pressure in the branch of the external carotid artery. That's why you can create a retrograde flow, and this branch going to the internal carotid artery and finally reach to the ophthalmic artery and retinal artery. All of these words are in the Bible of injectors. I mentioned this way, and you can free download here with the photo of this QR. And I always recommend that you need to read at least once in your life. If there, when you have the problem and you try to have a solution of this occlusion of ophthalmic artery, what shall be done? Well, usually have a theory of the 100 gold minutes, because after that you have a permanent retinal damage. You need to use a cannula of 25 gauge. You need to reach the retinal space that I'm going to show you. That's not easy. And you apply 500 hyaluronidase units every 90 minutes. You need to induce to hypercapnia. You put the patient in supine position. You need to add intravenous mannitol, timolol as drops, and finally acetosalamide as a diuretic. But I show here the way I tried that in the cadaver. It's not easy to punch in the lateral square, the lower external quadrant, and pass 2 centimeters of the needle to reach the retrobulbar area. And it's a straight area, it's really small. And when you apply a lot of volume, you need to be, in some cases, the one to create the ischemia of the artery, of this ophthalmic artery. That's why it's quite difficult. I don't recommend at all this maneuver. These are all the steps of this maneuver.
We have about 1 minute, Doc.
This is reality. The patient is in pain and restless, dangerous and unusual maneuver, impossible to inject such a large volume, because I mentioned that you are the one to increase, to create ischemia. You need to do a paracentesis to reduce the volume of the ocular glove, or you need to release the canthus ligaments. Ophthalmic or retinal artery are covered by ectodermal tissue that have a poor absorption, even you were successful doing the maneuver in the retrobulbar area. That's why I only find a communication from Chestnut in 2018 that he said that it was a successful maneuver, but there's a lot of other authors that make a systemic review, and they don't find this great successful at all. They don't find evidence of successful outcome with this technique. I offer you the Goodman technique. That is mean to put, here is in the cadaver, I put 500 units of hyaluronidase over the supraorbital artery or supratrochlear artery area, trying to go inside the artery, and even that in the surrounding tissue around this artery is going to be successful to pass at least part of this hyaluronidase to the orbital area. Ideal is you use an ultrasound, because as Leonie from Netherlands show us, you can use less unit at 50 or less than that to be successful when you are really sure inside the artery. And this is the way I act to, if I have this kind of problem. Fortunately, I never had to do it. I met this guy, Han Nguyen, during INCAS Bangkok in Jan 2023. And by this, I invite him to my Congress, to Symposium of Buenos Aires last year, because he had a great experience to recover the patient who have amaurosis. He used an intraarterial injection or hyaluronidase. He goes directly for the femoral artery, and he can reach ophthalmic and retinal artery and apply 500 units inside of the retinal artery. And nowadays, he recovered 70 cases of partial or total remission or vision loss, even 2 days as his average, and even one patient 4 days after the occlusion of the retinal artery. And here is the proof of his words and the way he recovered. Here is the retinal artery with the clot, and here is the retinal artery when he passed the cannula and the intraarterial doses of hyaluronidase. A piece of advice, as I mentioned, it's close to never too late to apply hyaluronidase. It was proved by my friend Han Nguyen. First, save life, because if you can infarction of the brain, you can save the life of the patient. Save function, because in some cases this infarction of the brain cause any kind of hemiplegia. Save vision, save the elevator muscle of the eyelid, save ocular muscles, save the skin necrosis, and in a delay time, you can solve granuloma, Tyndall effect, or unsightly skin. Finally, a trick for fat grafting over film. Oh, sorry for that. Let me look for this. 1 minute. I showed this complication with fat graft, and the way I can solve it with laser is another kind of filler we can use on the face. This is a complication of a colleague of mine that have an overfill in the teardrop area, and the patient started with arguments. He called a lawyer, and my colleague asked me for a no-surgical solution. That's why I offered a no-surgical solution. I use this diodo laser, and by this, I was able to emulsificate the fat in this area.
Doctor, we need to end about 30 seconds.
Okay, I have good enough for me. And here is before and after. And here is again the before and after of the patient in a close view. And again, return to my lecture with the take-home message. There is no biological inert synthetic filler material, as I proved. All committed filler may induce adverse reaction. All permanent fillers have higher potential of width. Trying to avoid it, of course. If you have any doubt about the origin of the filler, first step, the ultrasound diagnosis. Second step, the biopsy. But always you can find which kind of filler do you have. In the case of permanent filling, technology is not a good option. I warn you. There's always time to decide to operate. First, try to use mini-invasive maneuvers. And if you have an hypertensive injection of the retinal artery, well, first try Goodman technique, or you can call my Nguyen friend urgently. Invite all of you to the INCAS Americas Congress in Sao Paulo between April 11 to April 13. And thanks so much for your attention.